first and foremost, I'm excited to talk about dermatology because, as everybody knows, everyone in dermatology makes $1 million and works 3 days a week, right?
They love their job and they get paid buku bucks.
I can't wait to hear this.
The dream.
I can't wait to hear this. Welcome to the next episode of the Many Minds podcast, where our goal is to encourage collaborative community healthcare using many minds for better outcomes. We want to understand what makes your specialty special and how we can support you to provide better care for your patients. I'm Alex Davis, physician assistant, along with Tyler Murray, nurse practitioner.
General disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. We're just here to learn from each other and have a good time.
Who do we got with us today?
We got Scott Leatham, nurse practitioner. How long have you been practicing for?
First of all, thanks for having me on the show. It's
Of course.
Oh, yeah. Welcome, Scott. Yeah. Tell us how much money you make. And
should I start with that now, or like, how do I like?
I guess a formal introduction is nice. Yes.
How do I introduce that slowly? So I've been in dermatology for 8 years, and that was my first job from school, and
Nice.
I'm a nurse practitioner, so started as a nurse, even started as a CNA before that, and just kind of worked up. And it's been a lot of work getting into dermatology, but it's been paying off well.
So are you working for an independent practice then, or?
Yeah, so I work for an independent practice locally. We have an office in Lehigh and an office in Saratoga full time, and then we have a office in Provo, once or twice a week, just to kind of cover some extra patients down there.
What's the company name? Who is it?
Oh, Utah Valley Dermatology. So there's about 7-8 physicians, and there's probably about 6 or 7 other, like 8, mostly PAs. I'm the only nurse practitioner. They hired me, and they're like, we're going PA from here on out. No, I don't know.
Sometimes that happens. That's just how
Sure.
it is. Yeah, that's understandable.
But
I
no,
was just about to say my derm rotation in nurse practitioner school was like literally a slideshow of all these different moles and things like that. And I literally, it breezed by so fast. Like there's no way I could have understood all the different. And I remember they gave us this little paper of like how you would describe different lesions.
Yeah,
and
the terminology is a big deal.
It's like vast. And so for you to walk out of school into that space, I imagine it was a transition.
Huge transition. I mean, I think in school I got maybe 2 days, like max, on dermatology, and so it's just that's what everyone wants to know. I get a lot of texts and phone calls every day from like friends I didn't even know I had.
Yeah, of course.
They're like, "Oh, I know."
Can you look at this? Well, where is it?
Yeah, I mean, my phone gets blown up all the time. Like, I had this rash, but no, you're right. It's a huge learning curve, and so I mean, I started kind of slow. I mean, it took me about 1.5 years to, I think most of you guys, with different specialty fields, to get really like that groundwork underneath you to feel confident. And but yeah, it's a huge learning curve. Now, a lot of people think that like derm's super easy, but again, there's a lot of terminologies, and it's a very visual field, and you just can't see everything in a single textbook.
You absolutely
Yeah.
can. And I have to admit, and I'm going to tell you this
Okay.
as well. When I got out of school, my dream job was to be in dermatology.
This is like his third dream job he's described.
Okay, yeah, that's
Okay.
true. That's true. I wanted to be a CRNA.
Yep.
Reason I went to nursing school to become a nurse anesthetist. We've already said that in previous podcasts, but I'll tell you, the reason I did want to do derm was because I did 2 different clinical rotations with the dermatology clinic. 2 different dermatology clinics, and both of them, one was a PA, one was a nurse practitioner, both of them said they loved their job, and they also said they got paid buku bucks. And I was like, well, let's hear that. And I'm going to just be frank. This is what one of them told me. He said, I pull in $300,000 a year, but he broke this down. He said, well, but you have to remember, I'm bringing in the clinic about $1 million per year by himself. And so for that, I was like, wow, how are you doing that? Well, it sounds like they were allowing him to do the Mohs procedures pretty much independently with the physician, in-house in the other room doing procedures as well. And I don't know all the restrictions and red tape with that, but I was blown away. But then when you break it down, he's only taking 30% of what he makes, which means 70% is going back to the practice, and that's huge. And so obviously I thought I would like that mainly based on the money. I interviewed for one dermatology clinic. I don't even remember where it was. I was waiting and trying to get a job. I interviewed, and they obviously didn't like my face or something. They were like, "Yeah, you're not cut out for derm.
You don't have that derm face.
You don't got the derm face.
Your skin's a little lackluster.
Yeah, you just don't have that pizzazz." Yeah, so I didn't end up in it, and then fast forward, I got on with Dr. Edwards, but it was definitely a big desire for me early on. So
what drew you to it? How'd you get into it?
So I kind of have a distant relative actually that is the owner of Utah Valley Dermatology, and he kind of said years, even before I became a nurse, was like, "Hey, you should come work for me." And it's one of those kind of like, yeah, it's whatever. You're just saying that, and by the time I get my degree, it's going to be like that ship will probably have sailed or whatever. But I kind of kept that in the back of my pocket, and I did some derm rotations and stuff in school, and I mean, I'm with you, Tyler. I wanted to do CRNA, and I just realized that once I got in the ER, I was like, I'm not cut out for these ventilator stuff. It's just, but so I was like, I want to do something. And also, one thing that's nice about dermatology versus CRNA, it's like I don't have to work weekends, and like the on-call schedule. I mean, I have a little bit, but it's nothing compared to like something
there's a dermatology emergency. You get on call.
I mean, it's like an infection from like a biopsy,
okay.
But that's about like a true
the extent
emergency,
of it,
So I mean,
you probably do see something like a cellulitis though that would potentially be significant, maybe.
I mean, rarely, just because I mean we're working in controlled environments, so it's like but that's mostly like ER that see the cellulitis and stuff, but. I mean, we'll see like, those infections. Mostly it's like people leaving Band-Aids on, and I just tell them to take it off. But
saving the world one Band-Aid at a time.
Hey.
I mean, no matter how you guys know this, no matter how much you talk to a patient, like this is what you need to do. It's just bound to make phone calls for the weekend. But so that's how I, going through school, like as it kind of got closer and closer with going through the schooling process, that I was like, hey. Like family care and stuff's great, but I mean, I would love to specialize, and I just kind of had that in my back pocket of like derm would be a great field, and I think like it came from a lot of like working like hands-on in the ER. You're doing chest compressions and IVs. You're really just like not just talking much. You're really physical, and I think dermatology is very visual, very like hands-on type of a field. And I just think it kind of came natural to me, and just that's where I kind of want to go.
I love that, man.
Tell me about like the patient population and some of the pathology that you see. Then, what is it that you're actually treating and doing?
So I see, down from 6 months old to, or even younger sometimes, to 99 years old. And so I love that about dermatology. I like to see a variety of populations.
Actinic keratosis.
Done. Yes.
I got it.
Where's the liquid nitrogen?
Yes.
That's the dollar bills. No, I'm joking.
Yeah.
But and so I see a variety of ages. Actually, my average age, honestly, is probably in high school, to be honest. I see a lot of
acne,
the chronic acne, maybe
chronic acne,
Accutane.
Accutane. I see a lot of Accutane. What warts type stuff. But then the rest of it, is definitely skin checks and whatnot. But I think I gravitate towards, or maybe they gravitate towards me, just the younger population. While some of the physicians I work with, I think the older population tends to gravitate towards them. But
makes sense, yeah.
So it's kind of a fun environment. I get to learn all the new words that are like going throughout high school these days. And
of course, You
I still think
catch me up on that after this, please. Yeah.
Deal. But so it's kind of fun to see like the younger stuff, but also a mix of the older population.
I like that.
That's cool. And then what's the schedule like then? What is it you're typically working?
So my schedule's a little different probably than most in dermatology.
Okay.
It's like it's the dream job that I would want to be working 4 days a week, but I do work 5 days a week, but usually most of the time on Fridays, that's a half day. So I'm getting there about 7:40, and not leaving until usually about 5:20 or so on a typical day.
Okay.
I mean, so my last patient's usually around 4:00, and then just
Yeah.
phone calls and biopsy results
Cleaning
and stuff.
things up. Yeah.
And then usually about a half day on Fridays. But I feel like they're a full day because I'm seeing almost just as many number of patients on a Friday morning than I see on most weekdays. So I feel like I work 5
What
days
is
a week.
the average patient volume per day that you're seeing?
I probably average around 28 patients a day.
Wow.
Don't ask us how many patients we see, and I'm like over here sweating bullets.
Oh,
I was just telling you earlier.
I've listened to your podcast. I know. But you know, on a Friday morning, I'll see like 20, no problem. So that's like equivalent to like a 40 patient day on a Friday.
Is
So,
your MA
geez.
doing all of the documentation for the most part, or are you just having to sign off, or do you have to actually go back in?
No, they do most of it, so that's really helpful for us. So we have a great health record, you know, charting system on our iPad, and so that, you know, we're taking photos with those, but they're documenting it all in the room mostly, and you know, teeing up everything. So at the end of the day, I'm just looking over like, hey,
Making sure it's
making
all...
sure that everything's there that needs to be said and that was done, and so they really make it, you know, good on me or easy on me. So.
How about the hands-on portion of it? You talked about doing you liked all the ER, staying busy with your hands. How are you doing that now?
I do a lot of like procedure stuff, a lot of biopsies. I mean, you know, there's most days I haven't really looked at it, but I would guess I'm probably doing 15 to 18 biopsies on a given day.
Needle biopsies? Are you excisional biopsies?
Mostly shave biopsies. I mean, there'll be occasional like punch biopsy, you know, and then there's probably 1 or 2 procedures I do. A lot of lipomas.
That's right. Yeah, I didn't even think about that in dermatology.
Lipomas are fun. You know, most of them are pretty straightforward, but
Yeah.
if you know, occasional cyst or IND type stuff, which I know the classic, you know, like, oh, you pop a lot of pimples. I mean, actually, I don't. Like,
Yeah.
You don't?
I mean, I do, but it's not like you're watching, you know, Dr. Pimple Popper or something.
Which are not pimples. Those are massive abscesses.
Oh yeah, those are like
It's not a pimple.
something that's been like percolating for
Yes.
weeks to months.
Yeah.
But you know, so I run to that occasionally, but not as much as you would think. You know, most of it's pretty. You know, we're catching a lot of stuff like before it gets to those like massive things.
Yeah.
But I mean, I'll do an IND and pack a wound here and there. But yeah, luckily I have the stomach for that stuff. Luckily, but
Is that crazy to you when I talked about the Mohs procedure? I mean, are you involved in that in any capacity?
so that's a great question. So our Thursday mornings, I get there 7 a.m. and we start pretty early, and we do a lot of like Mohs on Thursday. So between like the group that I work with, we're probably doing about 15 cases of Mohs in conjunction to a lot of like, you know, extra like lipomas or cosmetic mole removals, to even some of like the atypical moles that we biopsy that, you know, or the melanomas that we have to kind of go back in and do these kind of things.
deeper and wider.
So we'll probably do about 20, 22 like procedures. I'm not on every single one of those,
Sure.
but about 15 of them are Mohs, and so I'm in there assisting with those.
I was gonna say, what's your role in that capacity? I mean, are you doing closures? Are you?
So I do a lot of the closures, and so, you know, and like the physician I work with, Dr. Myers, he does a lot of like, he tees up a lot of like the flaps and the grafts. I can graft, you know, if we need to, but he likes to do a little bit of like, let's get it in the right direction, then I'll finish the rest of it. Or if it's like a pretty straightforward linear closure, I'll do a lot of those myself. But so I go in there and I help him assist with like getting like the tissue that needs to be removed, and then, you know, we'll send it to the lab right then and there, and I'll do a lot of the colorization and
That's cool.
you know, and stuff.
That
So
is awesome.
but I mean, we're running from room to room. It's pretty chaotic, but controlled chaotic.
I was
chaos.
gonna say control chaos. There you go.
But and then Dr. Myers is the only one that does like the reading of like the results and things. So that's, you know, generally a Mohs surgeon. So I don't have any like specific credentials with that.
So
but-
you guys have a
Yeah.
lab in house?
Yeah, we
Sorry,
do.
so you're
No, you're good. I wasn't gonna say anything.
So I mean, we have
you
our
do
own.
like the frozen slides initially,
Yes, exactly.
right?
So
Yeah.
we have a Mohs technician that we actually have 2 of them, and you know, we do probably 30-ish kind of frozen sections, or, you know,
Yeah.
if you want to call it that, during the Mohs procedure. So it's probably about average of like 1.5 tissue removals that we have to do per patient. It rarely does. We have to go back 3 or 4 times, but it unfortunately does happen. But those areas that are delicate for like the nose and the ears, for example, we don't want to like
remove more than you have to, right?
Yes, we want the patients to look, pretty close to what they looked like when they came in, minus the cancer. But
sure.
And so we'll be very conservative with those and stuff. But
that's wild. There's so much that's going on that I think the outside wouldn't really realize within the dermatology setting, like all the auxiliary and all the things that are necessitated to really run that system. So
I was ready to razz you all day about dermatology being this kind of patty cake specialty, but dang it sounds kind of cool.
Yeah,
You're
there's
doing
a lot
cool
to
stuff.
Yeah, it's more than what people think it is.
Yeah, for sure.
Did you ever do a derm rotation?
No. We got grilled on how to use the terminology to describe skin lesions, and then just look at a whole bunch of gross pictures.
Yep. A lot of different moles. Yeah,
that was dermatology, and I always said in medicine I was pretty open to any specialties that I feel like I could learn to love, but like the two that I don't think I could really ever do would be something like women's health or wound care, which is probably what you see a lot, because wound care and these real bad skin conditions are just
Yeah, I mean, wound care is a beast, and rarely, unfortunately, I'll punt to wound care because I'm like, this is what they do.
We punt all the time. Yep, you should go to wound care. No, I'm just kidding.
But when I was in like my derm rotation, it was very minimal, and it was interesting. One of my the girl, the nurse practitioner I was following, she's like asking me like, what do you want to do? And what do you want to go? I'm like, I want to go into derm. And she's like, kind of gave the eye roll because she's like, everyone wants to go into derm.
Everybody wants derm.
Yeah.
I'm here. You're not getting my spot. Anyway.
I'm like, no. I really like, that's where I see myself. And so if I ever run across her one of these days, I'll be like, boom, I'm in derm now. So
I love it.
What about the flip side then? What are the challenges? What are the hard parts of this? Or what are the things that people maybe don't understand that are difficult for you?
I mean, there's a lot of looking like moles are out there that, we have to figure out. We have to make sure that we're like looking and searching for the right things. So moles are challenging, and it just takes practice, obviously. But rashes, I mean, you think that, the cliche thing in dermatology is like, if it's a rash, put a steroid on it. And you'd be right most of the time, but there are some things that you put a steroid on and you're going to just make it worse. And so
then you go to an antifungal. So
let's give them the clotrimazole, let's give them the betamethasone, let's just
just put a Band-Aid on, and then you don't see it.
Maybe a compounding pharmacy will mix them, get the steroid and the antifungal together, right?
Yeah, let's put some valcyclovir and just we're going to cover all our bases. But that's urgent care.
Okay.
We get a lot of these scenarios from urgent care, and it's like, you didn't get better, so we're glad you're in dermatology. So we see a lot of urgent care, follow-ups and stuff. But I think the rashes are tough, and you can go throughout your whole career and not see one specific condition. Or I haven't seen leprosy yet, guys. That's one thing I haven't seen. But and so it's just and so we have a great team over there, and so it's not uncommon to hey, let me go grab another set of eyes on this, because again, it's just two sets of eyes are better than one,
and it probably doesn't always look the same. Even the same pathology maybe doesn't look the same 2 or 3 times in a row on different people, right? Correct.
Yeah, you look at psoriasis and you're like, okay, psoriasis is pretty classic, but let's say you get psoriasis in your armpit area or axilla area, and it doesn't look like the classic psoriasis, but it's psoriasis. It just looks more weepy, and so it's just, even with this, as easy as psoriasis is, sometimes you can kind of get a little bit different ideas of what it could be, and that's not super classic sometimes,
So, and this is all very objective. Like, you're looking at these rashes and making a diagnosis based on symptoms, characterization. There really isn't, you're not doing biopsies unless it's a concerning cancerous cause.
No, we'll do biopsies on a lot of rashes.
Do you really?
And I tell a lot of patients, sometimes we won't know 100% what it is, but it'll tell us a lot what it's not. And that's at least gets us point in the right direction. And so, I mean, luckily there's cool things like PCR nowadays that we can run and make sure it's not some fungal thing, or the biopsy is very helpful, or And then time, with a lot of things cures a lot of rashes. And then when in doubt, the triple compounded medication,
Sure.
always pull that out in your back pocket.
Of course.
The migraine elixir, where they have the cocktail.
Yeah,
the
yeah.
migraine cocktail. Yeah, you have a
the-
cocktail for any
the
rash.
topical cocktail.
Yeah, it's the topical cocktail.
The topical cocktail.
I'm gonna let you run with that.
Strike that. Okay. Then let's just kind of get to what we were alluding to earlier. Tell me about the pay structure.
Oh, the
in
pay
dermatology, how do you compare to other specialties? How is the structure set up? What's your thoughts there?
So I'm in a little peculiar situation. So I'll tell you straight up, I'm salary based. So I don't get any like this $300,000, off of $1 million.
I was like, sign me up.
Yeah.
Sign me up.
Which is good and bad. And I'll tell you, like, in my profession, well, sometimes it's bad and sometimes it's good. So, I mean, there'll be some days, obviously, sometimes we're slow, and so I'm not having to stress about, like, the income there. But the opposite happens where you're just, like, slammed, and I'm seeing 35, 36 patients, and I'm definitely making the salary on that day for sure. So the doctor I work with, he's very good. He's my boss. He wants us not to be like doing things above and beyond what we don't need to do. And so
Right.
when you attach like revenue things, you in dermatology, in just like many professions, you can get a little carried away and do some unnecessary things. Like, oh, you got freeze 25 AKs or actinic keratosis, or biopsy things that you don't need a biopsy. You're like, like this is a wart. We don't need a biopsy it. It's not a cancer, which, there's always a few, providers out there that are doing that kind of stuff. But, so we keep it very, like, we do good work. And that's one of the things that my boss has always told us. Hey, we do what's appropriate. And so I get compensated just in salary. And so, yeah, I mean, when I first started, I mean, I was not making much money out of school because I wasn't seeing a lot of patients. I actually followed the Dr. Myers for like almost a full year and a half. Like,
oh my goodness,
I was doing a lot of his procedures and so a lot of his biopsies, but
just learning a way his techniques and what he does, how he looks at things.
Exactly. And just there we can at least talk about it and stuff. But, I was doing, like a lot of this hands-on stuff, but a lot of the counseling. And so I wasn't seeing like, and then slowly and surely I started seeing just the normal Accutane patients. And then it fully came, moved on from that to like skin checks and stuff, which can be.
They didn't just throw you in the fire, which is probably good in this setting.
Yeah, I mean, you hear a lot of like NPs in this field that like get like 6 weeks of training, and they like sometimes go off to like a distant rural city, and
hey,
like
you're on your own,
essentially on an island, and that's what's kind of cool about where I work is that like it's a team effort. And then again, like I said, we get together often to kind of like put all our brains together on challenging rashes because it does happen from time to time. But and so year after year, just as I took on more of a higher load, I just got a pay bump. I also, I don't know about you guys, but I do yearly contracts, so it's just like a way to kind of renegotiate.
Oh yeah, that's good.
That's a smart strategy.
It's kind of like at first was kind of like, oh, that's not like reassuring, but
yeah.
But it's been kind of cool to like, hey, evaluate year to year of like how things are going. So I've started off and then I've just kind of been bumped up every year, and so it's I can't complain.
Yeah.
I'm probably not making as much money as you think I am, but I can't complain for sure.
That's good. I like the process though of, I mean, I'm sure the actual signing of a contract is just formality, but it's the idea in our office. We call it a debrief of just a chance to sit back and reflect and kind of look at what's worked well and maybe what hasn't worked well and what new directions do you want to go, and just kind of a good way to review everything and see where you're at. And I think that's probably good practice.
Yeah, and I think it's a good time to just kind of reevaluate. And I mean, with the economy nowadays, it's good that we're looking at things on a year-to-year basis rather than like a 5-year thing where you're stuck in the same thing. And
that's my thought. I think that from an advanced practitioner standpoint, that's one of my biggest concerns is realizing or being told there's a ceiling, like you're not going to get past this point. And it's not that we need to make $1 million a year, but we also want to be able to live, right? And inflation is going up. So just this idea of this, annual conversation about where we're at, how much money we've made, what we're contributing, and just looking at the numbers in that standpoint, I think it's good. And I think that if we're always going to want to work hard if we know you call it the little carrot, right?
Yeah.
We just got to have something out in front of us. So having those conversations, it sounds like your practice has really done a good job of doing that and facilitating that. So that's remarkable.
And I feel like as advanced practitioners, since we're so flexible and dynamic, because you're not trained as dermatology specific, that's kind of the big difference with our physician colleagues is we don't have these specific residency programs. So you could jump ship, you could run around, and you see some of the advanced practitioners that are doing that, just bouncing here to here, and every other year they're at a different company or a different job, because I think they're kind of chasing that, I think, in my mind, of what's the next big opportunity. And I think you've been there for a long time. So what's kept you there? What's been the secret to longevity for you there in your spot?
I think honestly, it's just like, again, the variety, it's like, I don't just do full skin checks all day long. It's like, there's some easy kind of patients that come in and younger populations, but, I think it's a challenge. I mean, you're always like trying to make the next excision better than the last. And as far as like cosmetics and stuff, and there's a lot of like, like our patients are walking billboards for us, is what I say. Cause it's like, oh, where'd you get that scar?
Yeah.
And so, like we pride ourselves of like, hey, let's make good quality work. Let's make sure that we're not just like scarring up areas that, so it's a challenge for me. It's there's always new developments with like new medications, much like I'm sure with your professions. And so it's not stagnant, which that's what I like about it, and when I left the ER, I had one doctor who was like, oh, you guys in dermatology, just if it's wet, you dry it. If it's dry, you hydrate it.
Yeah.
And if it's itching, you just steroid it. And that's like the classic thing to say, but it's a lot more challenging than that. And I don't think that people realize that. It's I don't know. And so
that's good. I think that's good advice, because I felt the same way. You don't always know how to express that feeling, but the idea of it's a way to keep yourself challenged and engaged and always improving.
There's different like surgical techniques, different flaps, different grafts. There's artificial grafts or that we're using, or made of bovine type stuff. But and so it's just learning new things and how to heal things. And
I was going to say, there's a million different products that are constantly being introduced into the dermatology space. I witnessed it when I went through the clinical rotations. Like every day there was a new pharmaceutical rep, like pushing this is the new topical solution for X, Y, and Z. And so I think in derm, I can imagine that space is ever changing with just recommendations regarding, the certain types of medications you're going to use, how you're going to use them, and the utility of it and things like that.
Yeah, I've got a good friend that does wound care, and he was telling me, actually, Dallas, right?
Oh yeah, I know Dallas. Yeah.
Dallas, yeah. So Dr. Dallas, he's in wound care, and he told me one time that wound care really is at the cutting edge of medicine. That's where really all the newest, latest, and greatest innovations and technology and the science and literature is all pushing that dermatology/wound care world. Have you witnessed that? Have you felt that way?
Are we off base in thinking this?
No, I think you're right. I mean, in wound care, there's always like a new bandage that's like healing stuff way better. But no, I mean, I think that the psoriasis things have been like, game changer. And now eczema's having their heyday with like all these cool medications that we never had, 10 years ago, even 15 years ago. That are just like, I wouldn't say curing eczema, that's not the right term, but like totally making it super clear, which is amazing. I think it's one of like the rewarding things of my jobs is that I see the physical change. That's one thing about like family, not knocking family care, but I'm just not treating just a number as far as like, like what's their glucose, what's their, blood pressure, what's their like cholesterol, but we're actually seeing like physical changes in their appearance, and which a lot, especially a lot of teenagers care about, especially with acne and stuff. But no, and that's like, there's a lot of new medications coming out, and you think like, oh, we've cured psoriasis or essentially made it so that's like essentially, but they're all like coming out with new things, and it's fun.
Yeah, that is cool. On that note about like just the cosmetology or the cosmetic aspect of it, are you doing cosmetic procedures? Are you doing any type of like?
Tyler, you wouldn't want me doing cosmetic stuff on you, or
I mean, I was trying to sell it here, but
no. I do.
I'm trying to have that derm look, you know,
glowing skin.
I mean, I do a little bit. I do a little bit of lasers and stuff, but nothing too.
That's not really what your practice. Is it like the practice as a whole? Is it really set up for that, or
like our main doctor, Dr. Myers? He'll do a lot of cosmetic stuff, and so he enjoys it. He has a great eye for it. But I just don't find enjoyment with it. It's a different clientele.
It is.
And,
yeah.
you know, and
I get that.
Is there insurance coverage for that, or is that more cash pay?
Just cash pay straight, you know, and so,
yeah.
and so we'll do the Botox, the fillers, you know, and we have a med spa too. And so that brings in, you know, some patients.
Are there advanced practitioners running that in any capacity?
Not yet. You know, we have a couple estheticians, and then Dr. Myers will have, like, during his lunchtime, he'll do a lot of like the Botox and fillers and things. So
that's cool.
I've kind of stayed away from that. I'm focused mostly on just medical derm, and that's enough to chew on. And,
I respect that. Yeah.
I just don't want to go down another, you know, direction when I still haven't mastered the dermatology fully. You know, and you can never master it fully, so it's always challenging.
No, I like that.
But you don't want me giving you Spock eyebrows or whatever. So
Spock eyebrows, yeah, that's my thing. That seems like they would suit me. I can have some eyebrows, you know.
Yeah. There's your walking billboard.
Yes.
Everybody will know who you are at that point.
Yes.
Okay, this is another fun part of the show. We like to get into story time.
yes,
And you alluded to something early on of maybe something happening in your ER days.
oh yes.
And please continue your story for the rest of us to hear.
Yeah, so I made the switch. This was before, luckily, COVID. But I made the switch from med surg as a registered nurse to the ER, which was always my dream. And I think ER is like one of those where you like do it for a few years and you kind of move on. But I wanted to at least take that plunge before I became an advanced practice provider. But I think it was like one of my first days in the ER, to be honest with you. And you know, as a nurse, you know, occasionally you have a nurse that calls out, so you're always shorthanded. But and so like here I am, being like my second day. I think there was a code that came in over the radio, and so you know, it came in. There was a girl that came in had a syncopal episode, or you know, or she had a fainting spell, and so she came in first, and then a couple minutes later there was another patient that came in, full arrest. And I was like, man, here we go. This is like the real ER. This is like the show I used to grow up on when I was a kid, you know? And so, anyways, the story goes that he just was on his lunch break, apparently. He was a physician, and he was getting a massage. And we didn't know this, but the girl that came in with the syncopal episode was the one that was giving him a massage.
No way.
And it was, so we're doing chest compressions, and, you know, you always have like a house supervisor of the hospital coming in and helping. And she's like, wait a minute, this patient is Dr. So-and-so. And it was, you know, he had a full rest, getting a massage, and I'll leave it at that. But, you know, but yeah, it was just a kind of a weird situation. And, that was my first code blue I've ever worked on, and it was
two coded at the same time.
Well, one just had a single, just passed out,
episode,
and so
okay.
You know, and so but
the fact that was the therapist, you're saying that was the therapist?
That was the massage therapist that came in, and all of a sudden you know, the person that came was the one that was on the table.
Make of that what you will, yeah.
Make that. I don't know.
Leave this open to the imagination a little bit, I guess.
No idea.
But it was just a weird situation for sure.
Wild.
You know,
Wild.
ER was quite a. You know, we had everything from suicide to psych, but you know, I almost got taken out by someone that was overdosed. Like, I mean, it was full on, like, you know, the police were, you know, coming in, saving me from getting beat up. I mean, the ER is
no joke. It's the Wild West. It's the Wild West.
Yeah. So yeah, it's an interesting place for the ERs, but I at least had that experience of life. I lived it, and then I moved on, and I definitely had some good stories for sure. So as far as dermatology goes, I mean, I've seen some weird stuff. We once took out a BB out of some guy's leg that his wife shot him in the leg.
Oh yeah.
And ironically, we could feel it. We could put a magnet on the BB through his
Move
skin.
the BB up and down.
But when you get in there, you think it just would just show itself. But it was a little challenging. It wasn't deep, but it was just challenging to find it.
Was the wife there in the appointment with you?
Yes, she was. And
So they were still married.
they're still married.
She felt bad, or she was like, "Yeah, he deserved it.
Yes.
Can you get it out?"
But yeah, so we can call that a gunshot, guys.
Yeah, a gunshot wound.
we
yeah.
saw
Took care of a gunshot wound.
We saw a
There you go.
gunshot in dermatology, but so that was pretty interesting. We've had, we've taken out just massive chunks of like wood, out of some guy's cheek that got kicked by a horse. And,
Oh, jeez.
he kicked actually it was almost like a 4x4, and chunks of like wood lodged into his like cheek, and that was pretty crazy. I mean, that was a deep thing. That was one
goodness.
that we probably should have sent to the OR, on that one. But so we just foreign objects and stuff. We removed them. So I think like the cool stuff is like the cysts. Like that's where everyone wants. We record them, and so we have kind of our own little. Dr. Myers has his own little YouTube things.
Yeah.
We post some pretty crazy cyst stuff on there. That
I'm gonna have to check that
No
out.
kidding. We
I
gotta
mean,
take a
there's
look.
stuff that like I do like occasionally shoots across the room, and you're
Oh,
just,
jeez.
in the room you're just trying to like make it so the patient doesn't see that kind of stuff. So that's always a
Dude,
challenge.
if you have a big lipoma, I want you to call me because I want to be there in person.
You want to give birth to the lipoma?
Yeah,
and
I want to.
express
I
that
want to
thing out of
see
there?
that.
Oh, dude, I remove probably lipomas just about every other day. So
We got a new source for that. I've always wondered who to send them to, actually.
Yeah.
yeah,
So
we
there's-
there was one girl that came up from St. George, and that poor girl, she like came up not knowing like we didn't know what she was coming up for, but she showed up luckily right before lunch, and she's had this massive lipoma. It was probably the size of probably one like a children's football, like in her back.
I was not expecting that. Okay.
Yeah, and so she's just like, I came up from St. George
For it.
knowing that you guys are like one of the best in the state of Utah, because she's probably seen our YouTube channel and stuff, but and she's like, I want this out, and I want it out today. And so we're like, all right. And so we numbed it up really well, all local.
Where was it? Where was it?
It was on her like shoulder blade
Okay.
area.
Wow,
And
so
it was so massive that we ended up we had to remove skin just to remove the laxity. Most of the time that's not the case, but for her,
Because it had stretched out her skin
so much.
so
It had
much.
such laxity that
Oh, my goodness.
we were worried about like a hematoma and stuff.
Yeah, yeah.
So we just
Like with the dead space and like just all
exactly.
that stuff. Yeah.
So we just
All right.
removed it, and but I mean, it was quite impressive. I mean, not lipomas like that don't come around just every month. you
Now,
know,
is
but
that covered under insurance? Is
Yeah.
that,
Yeah,
that's
they
not
should be.
yeah, totally covered by insurance
That's
and
good.
stuff.
Well, kudos. Came up with some good stories.
Yeah,
I
so we-
appreciate
Dude,
it.
you just pulled. Yeah, this guy at the
This guy said,
beginning,
"Oh,
he's
I
like,
don't have
I
anything.
don't
I
know
don't
if
know."
I've got any stories. Yeah, you've got a ton of
you
stories.
just get me talking, guys.
Yeah.
They'll just be flowing. Just,
All right.
I might have to do a part 2. I don't know.
Okay,
Hey,
okay.
we're always about part twos.
My one experience with a pimple popper
Yes.
was an abscess during my student rotation at the prison.
Oh,
And so they let me into the infirmary in the prison, and in that setting, the patients
That's the
don't
real
really
wild, wild west.
they don't really get to say yes or no to letting a student be involved in their care. They just say
They have no choice.
This is Alex. He's a student. He's going to take care of you. And they say yes,
this
sir.
might be his first patient he's ever seen ever,
Yeah.
but he's gonna take care
Sure
of it.
enough, by chance, he had an abscess in the antecubital space.
Oh yeah.
by
yeah.
chance.
Just
In prison.
never happens.
Yeah, and so they let me get after
Commonplace.
it, and then after we were done, they decided to disclose the fact that he was also HIV positive.
Of
So
course.
luckily, there were no exposures and nothing happening there. But that was
That was
my
crazy.
one. That was my one dermatology experience that I'll claim.
Needless to say, you didn't apply for a job there.
I did not. It was a fun experience though. If you ever get a chance, go spend some time in the infirmary at the prison. It's a different setting.
That's,
Some of those cysts, it's kind of like off Monsters Inc., where you're like 2319. You're getting gowned up. You're like, is this
Hazmat.
Ebola or is
Yeah.
this like an abscess? You know,
Yeah.
you're like, I mean, you get sprayed in the face once, and you're
That-
like, never again. You
Yeah.
know? And so,
Eye protection, please.
yes.
yes, and so it only takes you once to like learn that. So
Awesome. Well, awesome, Scott. This has been a ton of fun. I appreciate you coming in today.
Good pleasure to have me.
I-
It's been fun to chat with you guys too. So.
Yeah.
Earned a ton of respect for what you guys do. What do you think, though, Tyler? What'd you learn today?
I was just about to say, the thing that I learned the most is you had no respect for dermatology. Now, me, I had all the respect for dermatology because I
course.
understood the magnitude of what they bring to the table. You
Yeah.
clearly did
These
not.
unsung heroes.
Someone's got to pop those pimples.
You know
Yeah.
what? I'm glad. And I'm glad you have a YouTube channel, Dr. Myers. I'm going to be looking for that. So,
Dr.
I
Dr. Derm, yes.
Yes. What is it again?
Dr. Derm.
Dr. Derm. All right, you guys heard it. So, but no, I learned a lot. I think it was fun. I think this was a great podcast. First and foremost, I felt good about this. So, but learned a ton. I appreciate what you do. I definitely would love to come in and see some of these procedures firsthand. I think that there's obviously a lot to learn about the derm space, and it looks like you're pioneering that. You're continuing that method, and I appreciate you coming on the show today. Really.
Yeah, thanks for having me. It's been great.
If someone wanted to catch up with you or follow up or connect with you, how would they find you?
I mean, you can reach out to my clinic, or you can reach out to me on, Facebook or Instagram. I mean, I guess people still do that nowadays, but yeah. Scott Leatham.
MySpace, yeah, you can hit me up.
Not my MySpace, but yeah, or you can just email me at scott@uvderm.com. So that would work out pretty well for me. So
Perfect. Appreciate it. Our clinic, we're available on social media as well. The Instagram, Summit Brain, Spine, and Orthopedics. Our YouTube channel, Summit Medical Institute. And then we always like to see people in person. So come see us Tuesday mornings, every Tuesday morning, 7 a.m. at the Mountain Point Hospital in Lehi, Utah for our in-person multidisciplinary case discussions. Special shout out to the production team as always. Dallin and Amelia helping us on the back end. Tyler, always appreciate having you here.
Dude, this was fun.
Well,
Yeah.
the audience, if anybody is listening, if there is somebody listening,
Hopefully
please
someone.
feel free to leave comments, ratings, reviews. Let us know what's working well, how we can improve, what you want to see, who you want to hear from. And
If you want to be
yourself-
on the show, please let us know. Love to have you. I think that's it, man.
That's it. Let's close up. Cue the outro music. This has been our 20th? 19th? What did we say? 19th?
I think we're somewhere in that
Yeah,
range.
19th
I like
episode
it.
of the Many
It's
Minds
130. No, just kidding.
podcast, where we are encouraging collaborative community healthcare using many minds for better outcomes. I'm Alex Davis.
I'm Tyler Murray.
We'll see you guys next time.
Peace.